My name is Anthony Kimathi. You are with the Addis Clinic team. As you see, we have Muna here, we have Dr. Paul. Dr. Paul has been part of us for the longest, so we consider him as part of the Addis Clinic. We have Felix with us and others that have managed to join that I cannot see. But I am the regional director for the Addis Clinic. The Addis Clinic is a digital health platform, as we say. It's a digital health organization that covers different programs. We have around 5 programs that we cover. Telemedicine being the mother of it all. And that's why you see, if we offer telemedicine, we are comfortable offering webinars in different areas and making sure that most of you can get an understanding of different topics and guidelines on different diagnoses that come through the platform that you use. The platform that we use is known as Collegium Telemedicus. It's an asynchronous teleconsultation platform where we don't ask for anything from the patient. We don't ask for any funds from the clinician. All we request from you all is to make sure that you send cases to the platform. And if you don't have an account with us, we create one for you. And what we do is that we have volunteer physicians, more than 100 of them, that people like Dr. Paul, who consult on different cases that we have on our platform. So if our case comes through the consultation and we need to triage it and then forward it, we consult on every type of case, except emergency cases, because as you know, as an asynchronous platform, we try to cover the most basic conditions and the most complicated conditions that we know sometimes you don't get physician consult in wherever you are. The second platform that we have is the Global Health course, where we partner with different universities around the world. We partner with Vanderbilt University, we partner with the Pittsburgh Medical School, and we partner with the Kenyatta University in Kenya, where we link up clinicians in Kenya and those students in different schools, 4th-year, 5-year students, and they consult on cases virtually. So they have a virtual consultation where they consult on different cases at a different time. And this is set up according to the platform that we still use, the Collegium Telemedicus. The third program that we have is HIV adherence program, or the Hem Health program, where we are in the western and Nyanza part of Kenya. We offer adherence counseling, we offer adherence messaging, and follow-up of patients that are on Hart and retroviral therapy, and most of them get assistance from our program navigators in the field, our peer educators, and our community health workers that we work in closely to make sure that the patients are not left out in the treatment plans. And in any case, any update that comes along, we still use the platform to consult on their cases. The fourth one is the Girls and Mother Safety Program that is in the coastal part of Kenya, whereby we work with young mothers, teenage mothers, and adolescents on different teenage pregnancies, gender-based violence, and sexual reproductive health rights in the areas. As you know, some of them are affected in these areas, but our main aim is to make sure that we offer them a safe space and follow up on their well-being and their health in different areas. The last one being our Somali Mother and Child Health Program. This one is in 2 IDP camps in Somalia, that is Beledweyne and Mogadishu, where we work with mothers and children. And these ones are taken care of by our 2 clinicians, Ibrahim and Hussein. They work with peer educators still and community health workers and follow up on different mothers and young mothers in these IDP camps. So our main aim is to make sure that they get the help that they need in those areas. But as you all know, the program that has brought us here is the telemedicine platform where Dr. Hart is one of our major consultants. And what we do is we offer monthly webinars. So this has been a topic that has been highly requested by many of you, that we discuss on 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 uh, on antibiotics and the clinical guideline for providers. Dr. Hart is an internal medicine physician that practices both in US and Canada, and he has been consulting for us different cases. He's very happy, very quick to answer any questions, and he's actually one of our lead physicians in the webinar sharing platform. He has consulted on different cases, different webinars, prepared different PowerPoints for different webinars for the longest that we have known us, and we have considered Dr. Paul as part of us. That being enough for the introduction, 7 minutes past time, I welcome Dr. Hart to take over and lead us. Dr. Hart will be leading the slides. You have a team that is ready to listen, ask questions through the Q&A area. If you can go into the chat and ask the questions, please do. If you have a question that needs for you to talk, please raise your hand and I will see it. But that will come later after the presentation is done. But if you have a question, mid the presentation, please type it in the Q&A and we'll go through it. Thank you. Over to you, Dr. Paul.
Good. Well, thank you very much. It's a real pleasure to be here again. First of all, I must say how impressed I am by the providers in Kenya. You face extremely difficult conditions. The severity of illness that you see is much greater than the average physician in the United States would see, because I've had many questions where I look and I say, I've never seen a patient, as I had a question about the other day, with a 3.1 hemoglobin. And that was followed by another patient with a 2.1 hemoglobin. So it's not unusual for providers in Kenya to get really difficult patients. Today's topic is, I chose for two reasons. One, it's important. And secondly, I've done some international volunteer work. And when I was in Zambia, we were faced with a situation where patients were coming in and it was a small clinic in a rural setting, and we didn't have many resources. And yet we were faced with the question, when do you choose to use an antibiotic? When do you not use an antibiotic? And that's, sometimes it's easy, but it's not always a simple thing. Let's move on to the first slide, please. Are you going to be moving it for me? Thank you. Okay, so why, choosing an antibiotic appropriately is very important, because if we use it properly, we can get immediate relief for our patients and benefit. But if it's inappropriate, we may harm them. If we overuse antibiotics, we're asking for resistance, and that is a worldwide problem. It's the United States, it's Canada, where I was trained, and it's all over Africa, South America, worldwide. It's also a burden on the healthcare system. If every time we use a product, an antibiotic, do a test, it costs money. It's a burden on the system. And it can have impact if we develop resistant bacteria because we've abused or overused an antibiotic. It leads to a global crisis. There are 2.6 million antibiotic resistance each year. We have worldwide approximately 36,000 people die. And right now, bacteria are becoming more and more resistant. And what happens with a patient, if I'm using an antibiotic that I shouldn't be using, it disrupts our normal microbiome. And of course, there's billions of dollars in excess healthcare costs. So there is a penalty to pay. Next, please. Now, we talked just a little bit. There's the clinical impact, longer hospital stays. We have to change from one antibiotic to a more expensive. People die early. Um, these enterobacteria in a report done in 2024, 53% increased resistance. Therefore, it's a global challenge. So I'm not trying to say that you should not use an antibiotic, but we have to be careful when we do. Next, please. Okay, when do we consider using an antibiotic? One second, I'm just going to try and minimize something's on my screen. I apologize. Okay, the first thing you do, obviously for all patients, is our history and physical examination. So let's use this as a way of helping us as a guideline to whether we think that patient needs an antibiotic or has a virus or something that is self-limiting. Next, please. Okay, what do we want to look at from the patient history? Have they had a fever? Now, our patients may not know what their temperature is, but they sure know if they've had chills, if they've been hot, sweaty, how long it's going on, and what else they've had along with it. If we're thinking of a urinary tract infection, was it painful? Were they going more frequently? If they have flank pain in the history before we do our physical examination, maybe they have pyelonephritis. Do they have a cough? Does the sputum they bring up sound purulent to you? Now, years ago, I was told that white was a virus and colored was a bacteria. As we all know, that's not an absolute. It's a guide, but it's not an absolute. Are they short of breath? Another important question. Looking at the skin, if there's a skin lesion, is it red? Is it tender? Is it warm? Is it oozing pus? These are all things that we can ask and, of course, observe. And what are the risk factors? You know, has this patient been exposed to somebody else who may have treated who had pneumonia? Has this patient been just recently discharged from hospital for a serious problem and their immune status may be somewhat compromised? Have they been traveling? Has they had a procedure? Do they have an indwelling catheter for some reason? These are all the risk factors that we can get from our history. Next is when we move on and we examine the patient. Yes, we'll take their temperature. If they have a heart rate that's elevated over 90 or 100, if they're breathing more rapidly, if they got low blood pressure, these are all indicators of a more severe infection. And when these are present, we're going to think of using an antibiotic rather than observing them and seeing what's going to happen. Now, the physical examination, if there's flank tenderness and you're thinking of pyelonephritis, as we'll see later, that's one of the indications to start immediately an antibiotic. If you listen to them and you have rowels and decreased breath sounds in a segment of the lung, you're going to think of pneumonia and again think of starting an antibiotic. Do they have signs of meningitis, neck stiffness? If you look at the skin, is there suggestion of cellulitis or a deeper lesion or a cyst that may become infected and discharging towards the surface? So these are all part of our physical examination. So by the time you combine our history and our physical examination, we have a pretty good indication of whether or not we're thinking of using an antibiotic or not. The patient who comes in is afebrile, normal heart rate, not short of breath, but says, doc, I've had a cough for the last few days and I'm concerned. You listen to the lungs and you may not hear anything or maybe an occasional rhonchi. That patient, you're less likely to want to put on antibiotics. That's more likely a virus. And that we can all do without resorting to any lab tests. Because if we're in a situation where it's not easily available, the patient can't afford it, which is an issue in the United States where not everybody has insurance, we can help make those decisions. Next slide, please. Now, what do? We do our initial assessment. We've talked about that. Now, what are the basic tests that we need to do if they're available? Then we'll talk about cultures and diagnostics. So let's move on to the next slide and talk about the basic tests you'd want to do. A CBC. If we can get a CBC with differential and it shows that the white count is elevated greater than 10,000, and that's not an absolute number. If it's 9,500, but we have a left shift, then with bands, maybe even more than 10%, that strongly suggests that we need to use an antibiotic. If we do a urinalysis for the patient who's having some symptom of urinary frequency, maybe a little bit of burning, and we notice white blood cells, that the count is at least 5 or greater, then, and maybe there's red blood cells additionally, that sounds like it's important for us to consider and put them on an antibiotic. Now, if we can obtain a blood culture, that's great. It's not feasible in every site. Many times when I did my international medicine, I was able to get a CBC in a urine. Blood cultures were a separate problem, and it does help. But as you know, a blood culture that's negative may not necessarily say that there is not a bacteria. It may just mean that the blood culture is negative. And as a side for any test, that test result is just that one specific item. So a CBC, which is only at 8,000, is an indicator that may not be bacterial, but it's not absolute. And we have to take each test in relationship to the entire picture. So these are the sort of the tests which ideally we can get if it's feasible in our situation. Next, please. Okay. Now, if we have advanced tests, and again, this is often in academic centers, a C-reactive protein is a great marker of inflammation. The PCT, again, a nice marker if we can get it. If we can't get it, we can't. A rapid stress test, streptococcal test, is nice. It's 95% specific. But when I was in Zambia, that was a question all the time. People came in, I've got a sore throat. We looked at it. It was red. They'd had a little bit of a fever. We did not have strep tests. And as you know, if you don't treat streptococcus, there are certain strains that can lead to rheumatic heart disease. So the question said, should you use it or not? It'd be nice for MRSA if you can do a nasal swab. Again, not always feasible. So these are advanced tests, which would be nice if you can get them, not critical. Next, please. Okay, when do you start antibiotics immediately? And I've noticed in many of the referrals that I get that antibiotics have been very appropriately started immediately. But there are some cases where I think I might have held off. And now it's awfully hard for me to judge. I'm in Canada right now, and I'm usually in the US where I live. I'm not seeing the patient. I'm just seeing information on a referral. So I can't accurately judge. But in certain scenarios, we really want to start that antibiotic. You really want to start that antibiotic right away. As an aside, the population that I deal with now, I just do, are homeless in the United States, living in a homeless shelter. I have no tests that I can get on these patients. I've got to go by what they tell me. I have a nurse at the other end who can observe and take a picture of the lesion, get a temperature, do the heart rate. And I've got to use the same guidelines that I'm asking you to do. And in some cases, we do have antibiotics we can handle them right away, not intravenous, only oral. If they need intravenous, we have to send them to a hospital. Next slide, please. Okay, septic shock. That is one of the areas where you really want to start an intravenous antibiotic. And if they have all of the elevated mental status, if they're hypotensive, a temperature greater than 38, heart rate greater than 90, increased respiratory rate or white count, and sometimes you may know what the source is, but if you think you have a septic patient or a patient going into septic shock, you want to start them on a broad spectrum antibiotic quickly. And that gives your patient the best chance of doing well. Pyelonephritis with say systemic signs. That patient comes in, they've got a fever, they're complaining of flank pain, and you examine them, they're tender in the costrovertebral angle. They've got a urinalysis, which shows white cells plus or minus bacteria. Again, signs of a general illness. That patient is started immediately. It'd be nice if you can get a urine culture because somebody can give a urine pretty quickly. But if you can't, you've got your urinalysis, if you can't culture, you start that patient on antibiotics right away. And then finally, bacterial meningitis. Again, you do not want to delay for getting a CAT scan. You don't want to delay for an LP. If you can do a lumbar puncture, nice, but don't delay. Start that patient with the photophobia, sometimes a rash, the fever, right away. This is life-saving for these patients. And it's something that I'm sure all of us would do in these situations. Next slide. Now, there's something called the Stanford Healthcare Sepsis Protocol. What it is a list of antibiotics based on where we think the infection is. Is it a pneumonia? Have they had a surgical procedure and it's in the abdomen? When I answer any of your questions afterwards in writing, I will include a copy of that for you. Now, realize these are American guidelines. Stanford is a US university, but they're pretty specific and I think they will work universally. You know the pattern of response to medications in Kenya. Unfortunately, I don't have that, but I will send you the Stanford guide, which will give you at least one set of recommendations. And again, I'm sorry, I don't know which antibiotics are easily available to you and which are not. So use this as a guide. If there is an antibiotic that is not available and you're not sure of an alternative, please get back to Anthony. And he'll send the question to me. You can send it to me directly, and I will get you a source or a recommendation for what is alternative. And if you could list me what your options are, then it's even easier to make a recommendation. Because I think this is a nice guide to put aside someplace where you're practicing in case you have to look it up. Next, please. Okay. Now, what do you do if we don't have lab tests? So we've been talking about this along. So we do our assessment. We say, what are the chances? And we start treatment. And then you see how your patient is doing. So you get a patient who comes in, you think they have pyelonephritis, you put them on IV antibiotics, you see how they're doing over the next 24, 48 hours. You're going to be using, if it's pyelonephritis and you have access to IV antibiotics, that would be the ideal thing. If they're clearly septic, you want IV. If they're meningitis, you want IV. You're going to admit that patient. If you do have a facility to admit them or someplace where you can observe them. And that's the process of what do we do if we don't have lab tests available. Next, please. Here we go. So we maximize, I'm sorry, I don't know why these things can come out at the top, but you maximize your clinical data. So you rely, when you have limited diagnostic abilities, you're looking at the fever. How long? What's the pattern of it? What are your symptoms? What are your physical examination? What are the risk factors? You follow up. You look at treatments based on, in your community, what the local pathogens are, what the resistances are. Are there any infections that are spreading through the community? And you monitor them. Now, if we're not sure, use a narrower spectrum antibiotic rather than a prolonged broad spectrum, if that is an option. And all these you do taking in account what is available to you. These are guidelines. You know what's available in your community. Now, that's okay, please. Next slide. You're right. Okay. How do we choose the right antibiotic? We've gone through everything and we've decided we need an antibiotic. So let's look at what we do to try and make sure we're choosing the appropriate antibiotic. Next. Okay. Look at the most likely causative organisms. Where's the site? What is there in our community? And do we know of any resistance? If you see a number of patients with pneumonia that you've started on one agent and they don't seem to respond, okay, you have to move on. Do they have a history of allergies? As you know, people who are allergic to penicillin also can be, there's a 3 to 5% are also allergic to cephalosporins. So anytime I have a patient who's allergic to penicillin and I want to start them on an antibiotic, if a cephalosporin, cephalexin is my drug of choice, I always ask them, have they been on it before? And if no, then I'm a little reticent to use it, or if that is the best choice, to let them know that we have to monitor them carefully. If I have indication that they have compromised kidney or liver function, they've abused alcohol, perhaps, or have had a renal calculus recently and were found to have diminished renal function. I want to look at the antibiotic I'm choosing to make sure that it's not going to be primarily metabolized by the liver or excreted by the kidney if that's their problem. Drug interactions. I always ask a new patient that I have not seen before what medications they're on. I don't want to give them an antibiotic or any other medication that's going to interact with something that they're already on. Now, there are free, and I believe I sent it and I can send it again, there are free interaction checkers available on the internet where you just list the medicine that the patient is on, and they'll tell you yes or no, there is a drug interaction. I cannot personally remember every drug interaction out there. It's totally impossible. We have so many drugs and so many potential interactions. So on a regular basis, I use a drug interaction checker. And if you need one, please, I'll get one sent for you that you can get on the internet. And I was taught in medical school, every woman over the age of 15 can be pregnant. Always ask for the pregnancy status. And if it's unknown, be very careful what you suggest or try for a medication if the patient may be or is trying to get pregnant. The narrowest spectrum antibiotic, of course, we want to use that. Use the appropriate dosing for the antibiotic. And if it turns out that we can get a culture, and it turns out that the medicine we chose is a broad spectrum antibiotic because of the presentation, and we get information back that we can use a narrower spectrum antibiotic, switch. It puts less risk on the patient. So that's that. Next slide, please. Okay, here's some examples. Um, uncomplicated urinary tract infection. These are American guidelines from 2022, not international. One, nitrofurantoin for 5 days. Two, trimethoprim sulfamethoxazole twice a day for 3 days, as long as you don't have a problem in your community. And the fluoroquinolones, um, try to avoid them because of the increased problems with the drugs causing side effects. They're no longer considered, at least in the US, first line agents only for people who have more serious problems. For a community acquired pneumonia, amoxicillin, and then doxycycline. Um, and complicated urinary tract infection, ceftriaxone, which I see people using all the time, great antibiotic. And then the others are listed. I don't need to read it for you. And again, with the skin, cephalexin, non-purulent cellulitis. And again, the note about the fluoroquinolones, because not only is the resistance increasing and the C. difficile, but tendinopathy, peripheral neuropathy are problems. I have a colleague whose wife was put on a fluoroquinolone and developed a marked peripheral neuropathy. So it's not a minor concern. And this particular woman had never had a problem, had not been on many fluoroquinolones, but never had a problem. She went on it for an infection and had a serious problem. Next, please. Okay, so here, just going through the steps. We confirmed that we think you have a bacteria. We look at how severely ill the patient is. We select, and then as more information comes in, if we get a culture, we look at it, we look at how the patients are doing, and we make changes. And then we are always documenting what we're doing for our records and the patient's record. Next. And that's it. I hope that that's valuable. I will send off the Stanford guide and any other information that you would like. And I hope that this has, again, been of some value, because I know you're faced with very complex patients and patients who have significant chronic illnesses. Thanks, and I'll ask Anthony to carry on.
Thank you, Dr. Paul. I think that was a very good presentation
Thank you.
for everyone. I think for any questions that you have, as I go through it, the main question would be, I think there's one that is coming through, but for everyone, I see we have a big number in the participants panel. Please, if you have any question that you think of on antibiotic, the good thing about Dr. Paul is that even if he doesn't answer the question right away, he will go back, research on the question, and then give us an answer on email, and I will forward to whoever has the question. My email is Antony, ANTONY, at addisclinic.org. That's my email. You can forward any questions. You can request me to send you your the recording. You can request me to send you the PowerPoint presentation. And even if you have any questions regarding this topic that you come across later, but you need to ask the question, please forward it to my email. I will repeat the email again: Antony, ANTONY, at Addis Clinic. Addis as double D, ADDIS, clinic.org. There is no space. The first question was from ESO First, but I think the question was on Whether the Addis Clinic can expand its programs in Ethiopia, that's a matter of working. And I think most of the work that you do is recognized in different areas. But on the telemedicine part, anywhere in Africa, you can consult us. Anywhere that you are in Africa or anywhere in the world, actually, we have a clinician in Afghanistan that sometimes sends cases. So please, if you have any question that, if you have any consult that you need targeted or helped by able professors or physicians like Dr. Paul, please let me know and I will create an account for you. Felix is here too. Felix email is felix@addisclinic.org. PHELIX @addisclinic.org. So if you have any question about that, please forward them to our email. The second question comes from Felix. What could be the best choice of antibiotic for children with sickle cell anemia?
I will find out and get back to you because I can tell you in the United States, I've not treated, but best antibiotic for sickle cell. I will let you know for children. Okay.
Thank you. Thank you. The next question would be, so something that you will understand is that any of these questions that are being asked, please send me an email, send me your emails, any of the questions that will be asked by any of you, and you need an answer. If Dr. Paul will respond them in the next 24 hours, if he responds to them and I saw your email as part of the questions, I will forward it to you. The next question
also,
is,
if I may say too, please, because we have fortunately a good number of participants today. I really enjoy preparing talks for the Addis Clinic. Please send me or send to Anthony and Felix any suggestions of topics that you would like a talk on, because it'd be my pleasure to do one for you to try and help. So I'll leave that there, but please, any topic you want, let me know and I'll do the best I can to provide as best a talk as I can do for you.
Yeah, thank you, Dr. Paul. We have these webinars every month.
Right.
So for the participants that we have, please don't shy away. Any topic that you think can be discussed in this group, please let us know, and we'll be very grateful and ready to prepare a presentation for that and have a day of your choice. The next question is, it's not a question, it's a compliment. The presentation was good and clear, and I'm grateful for it. That's to you, Dr. Paul, from Agri. And we have somebody is asking, is a fever an indication for an antibiotic? Not sure if you answered this.
Yes, that is definitely one of the indications. When you're assessing your patient, you're going to ask them if they've had a fever. They may not have a thermometer, but they know how they felt, if they were warm, sweaty, and then you check it. And if it's elevated, that's one of the very striking reasons why you may want to do it. It depends how high it is. If it's just a little bit elevated and they only have other mild symptoms, you may want to hold off. If it's a significant fever with cough, with purulent sputum, and you listen, you say, gee, I think they have a pneumonia, definitely you'll want to do that.
Thank you. And there's this question, Dr. Paul, on the difference between intermittent and remittent fevers.
It depends on what's the cause of the fever. I'll get you more information on that in the choice of antibiotics between intermittent and constant fever and choosing an antibiotic.
Yeah, I think this question comes because of the parasitic
right.
Or the areas laden with the malaria.
Right.
In malaria, we don't expect you to put an antibiotic.
Yeah, and malaria in Kenya is a major issue, as I understand.
Yeah.
Yes.
Thank you. There's Vincent. Vincent is asking, what's the average positivity rate of blood culture results at your facility?
I've actually I'm basically retired except for doing this type of work and supporting, as I mentioned, the homeless. So I don't have a facility, but what I can find out for you is the average positivity rate in the U.S. for positive cultures in the presence of a infection.
Thank you. That will be answered. That will be answered as part of the questions, Vincent. So please send me your email, and I will send you the answers. I will not. Please, a request of everyone here: shoot me an email. Just even send me your name, and I will know that you are part of the group that was in the webinar, because it will be so hard to know who attended and who did not attend. But what I will do is that what we do, we create a Google Drive for this and share the link to everyone that attended, so that they can go through the PowerPoint, they can go through the presentation, and they can go through the answers that were responded to later. So please share your email with me in my email. I'll remind you again, anthony@addisclinic.org. The second question, the fifth question is from Sherrington. I would like to know if antibiotics are important in surgical procedures, putting in mind that they are carried in sterile conditions.
Right. I will get you the current guidelines because it used to be that in certain procedures we gave antibiotics, and I know that has changed recently. So I don't have the current guidelines, but I will get you the current US guidelines for which surgeries should have the patient on antibiotics prior to the surgery and which conditions, because I'm sure there are certain conditions where we should put the patient on an antibiotic prior to, or should they be giving antibiotics during the surgery. And yes, so I'll have that for you.
Thank you. I think the next question, Dr. Paul, is on cases of ORIF for any bone fractures. Do you recommend patients going home with antibiotics?
Are they talking about probiotics or antibiotics?
No, the question before, Billy, I'm asking the question on the same point from Sherrington.
Oh, I'm sorry. Yeah.
On patients on ORIF that had bone fractures, most probably the tibia or the femurs, and then put on ORIF. Do you recommend them to go home on antibiotics?
I will get you the answer.
Thank you. We have another question on Billy. From Billy, can probiotics be used as a preventive measure to prevent sepsis in infants, mostly term babies small for gestation age and premature? If yes, how long?
Is that a practice in Kenya?
I think Billy can tell me this. Billy, are you available to tell us why you asked that question?
Because I'm not familiar with that in the US.
Billy, I can unmute you, and then you can talk, Billy. You can unmute. Yeah, go ahead.
I was asking like that because there is a research which is currently going on, and babies also
That's going on right now in Kenya, that research?
Yeah, it's in Kenya.
Oh, yeah. Okay. I'm not aware of it, but I will see what I can find out. That's interesting. And probiotics I know are very safe. So it sounds like a worthwhile thing to do, but I'm not an expert. So don't take that as an answer, but I will find out what I can.
Okay.
Thank you, Billy. I think that will be responded to in the answers too. We have a question from Miriam, and this is a very serious question, Dr. Paul. how do we hold pharmaceutical companies accountable for the promotion of unnecessary antibiotic use?
That's an excellent question. I wish I had a good answer. I don't know. I don't know the pattern in Kenya, but when I was practicing both in Canada and the United States, we had representatives from the pharmaceutical companies coming around all the time to promote their medications and why we should use their antibiotic and all the indications. And clearly, it wasn't for the betterment of the patient. It was for their bank account. All we can do is just say no. But I don't know how we hold the companies accountable. Excellent question. And I wish there was some answer that I could give you because it's a really important issue.
Yeah, before I allow Bernard to, Bernard has raised his hand. Before I allow him to talk, I think, Miriam, one of the things that we do and will go to most of the people that took an oath to serve patients as clinicians and healthcare workers is that always put the consideration of put the patient first. Please, because I know it's the same case that is happening in Kenya, Dr. Paul, that we have what we call medical representatives or drug representatives. And since they are in the market to sell their medications, they will always make sure that they will always try to sell you their medication, try to entice you, buy you something, and you will end up writing the fourth generation cephalosporin to a patient that has never even started the first generation. So for that, I think it's more dear to us as healthcare workers to make sure that we serve the patients first more than the bank or the people that are coming to sell their medication to us.
Right.
Okay, I can go to Bernard. I will allow you to talk. Bernard, you can unmute yourself. The floor is yours, Bernard. You are unmuted, Bernard. You can talk. I can't hear you. I think there's a problem with Bernard's side. He had his hand raised. I unmuted him, but I cannot hear him. So if Bernard, you need to ask a question in the your side, there's a microphone problem. Please type the question in the Q&A and I will read it out. Read it loud. Let's go to Abera. Nowadays, there's a concern regarding malaria drug resistance. Is there any drug currently more effective and broad spectrum than Coartem? Coartem, I think it's a artemether that is going manufactured or currently being used.
I'll find out because the last time I treated a case of malaria was when a patient was given by the pharmacy the wrong preventative drug when they went to Africa for a business trip. And that was many years ago. I will find out for you what is the best current drug for Kenya and what is under investigation, because I know this is an area where there's active research.
Thank you, Abera. I have your email. I will reach out to you when Dr. Paul responds. We have 10 minutes. In centers from Felix, in centers where lab facilities are not available, when do you consider switching from one antibiotic to another?
Excellent question. We have to use our clinical skills then. We look at the patient, you know what we're treating them for. Pneumonia. You give your first choice antibiotic. You see how the patient does over the next 24, 48 hours. If they're not improving, consider making a switch. If they're slowly improving, you may want to monitor them a little longer, but you have to then use your clinical skills, because you can't go back if you don't have a facility where you can do another white count, where you can do, if you couldn't get a culture. It's got to be our clinical skills.
Thank you. Bernard, I've allowed you to talk. Please unmute yourself. We still can't hear you, Bernard. Bernard, I can't hear you. Abera, unmute yourself.
Okay, thank you very much. Thank you, Dr. Paul, to have this important topic to discuss. And happy to see you again. It was very important topic. So I have a question regarding the typhoid and the typhus fever in our country, Ethiopia. Most of the time, these tests like Widal and Wilfelix test is sent. But regarding the sensitivity and the specificity, there is a problem that all the clinician most of the time in primary health setup, especially, send those tests, and if they come positive, whether it is strong or reactive, they will give for every patient the antibiotic. What's the comment regarding those tests? How do you say they should be stopped, or what is your comment on this details as well as on the laboratory investigation?
So if let me sure I understand. So if you are presented with a patient and you think they have typhoid, you do the test, you send it off, and then you start them on treatment. Is that correct?
Yeah, but
Okay.
my concern is that uh, is those tests even has to be sent, because
Mhm.
even the healthy person who we send, for example, those some patients ask to be investigated, and then if we send them, even the test will become positive.
Right.
Yeah.
So, well, I mean, if you think the patient is positive, then I mean, I would start them on and stop them. How long does it take from the time you send off the test until you get a result?
Almost 30 minutes. It come within 30 minutes.
Oh, then I would wait for the test. If you could do it in 30 minutes, you don't have to send it to another outside the area.
Yeah, yeah.
No, if it's
It's,
local, then if clinically the patient you think they can wait that period of time, which is not a long time, wait and then start them on treatment once you get the result back. Because if it's negative, then you're looking at another possible illness. You may want to consider what else it could be.
okay. Okay. Thank you very much.
Yeah.
Thank you, Abera. And Dr. Paul Abera is from Ethiopia. So you receive cases from Ethiopia too.
Oh, beautiful.
And yeah, so I will try and be as fast as possible. The next question comes still from one of us, one of our friends, Shellington. I have seen in Asian countries where you can't buy antibiotics without having a valid prescription followed with a laboratory test. Can we adopt that to reduce antibiotic resistance? Again, thank you a lot for the amazing work that you do from Shellington.
It sounds like an excellent point, but in Kenya, how many people can get the appropriate laboratory test in the communities that you folks serve? I mean, looking at my international experience going up the Amazon River, being in Ethiopia or Zambia, we didn't have access to the test. So we had to go by our clinical judgment. Ideally, if you have a test that you can come get back in a reasonable time frame that's not going to harm your patient, ideal. But if you can't get a test or you can't get it back in a time frame where your patient wouldn't suffer in, then it becomes difficult. It's in a situation in Asia where I guess they have much more availability for testing and reporting than other parts of the world. That probably would work. But I know there are many countries that I've been in where you can walk into a pharmacy without a prescription and get a medication. and just say, I want whatever the product is. And they give it to you. Now, and that can be very dangerous, but it does exist.
Thank you, Dr. Paul. I think that has been answered. How do you manage someone in a region where there is no access to labs and has been on antibiotics with no change?
We change the antibiotic. We see what the condition we're treating. We look at if it's a urinary tract infection. I know from before, if you recall, nitrofurantoin was the first drug. Let's say we've chosen that. We switch it to the sulfamethoxyl trimethoprim. So you would just say, clinically, they're not doing better. They're having problems. We'll make the switch.
Thank you. So continue switching until you get the right one.
Right. And as far as all my slides, I just see the next question. All my slides are available to everyone. And if Anthony can, or Felix can, please send out all the slides every time to everybody, because this is for your use. And if you have a question about the slides after you look at them, please get back to me. I'll gladly try and answer the questions.
Yeah, so for everyone that is sending me their emails here, I will send you the answers and these questions. Sure. We have the third last question. Are antibiotics still indicated in postpartum mothers, post-delivery? Is it necessary?
If you've had an unremarkable delivery with no sign of infections, it's not the policy in the US or Canada to put somebody on an antibiotic. Now, most of the deliveries in the US and Canada are in hospitals, sterile conditions. If somebody is having a home delivery and you're concerned about the risk of infection, then you have to assess that. But, as a routine, if there's no risk for the mother, no conditions that she, you don't think she's coming into the delivery having contracted a pneumonia, a urinary tract infection, or whatever you're worried about, no. If there is an indication based on your evaluation of the mother postpartum, definitely you would use it. But I wouldn't use it as a routine, because then we're getting into all the risks we talked about before.
So we have a recommendation here. Probiotics can be used for immune support, but can't be used to replace antibiotics. When you use antibiotics, they reduce the gut normal flora that can worsen the condition. That was why they are recommended after antibiotic use. Shellington is a pharmacist, and I think he is more conversant in that part. So that's his view.
Good. Yeah. Yeah, super.
Yeah, thank you, Shellington. I think in the next webinar, Dr. Paul, I will request Shellington to join us as one of the panelists I think if we have a question that mostly regards the use of medication and drug use, Shellington is conversant in that, and I will request him to join as part of the panelists next time. So for the team and the participants, please, when we request you to join us in the next webinar, please do so. The last question comes from Bernard. How can HIV programs align with the Sustainable Development Goals, what we call the SDG, SDG 3 and SDG 13?
I will try and look that up. I honestly don't know, but I will see what I can find out.
Thank you. I think it all ends there with a bearer saying thank you to you all. But as we conclude.
And I will have answers by the end of, I'm at 2:00 in the afternoon. I know you folks are 9:00 at night. So for tomorrow morning, I'll make sure that Anthony has all the answers in his email and he can distribute them to you.
So for everyone that registered for today's session, we'll forward you the link to the Google Drive that will have the answers, the recording, and the presentation. And if you get my email, please, if possible, tell us what you think should be the next topic. And we will set a date, we will set a time, and invite you all and share all these with your colleagues. And as Dr. Paul has always said, tests sometimes are not indicative of antibiotic start. Sometimes if a full hemogram, what we call a CBC is what we call a full hemogram in Kenya. If a full hemogram still comes negative of something, and your intuition tells you that there is a probability of bacterial infection, please start them on antibiotics. So mostly, this is your clinical guideline. And as we do these classes and mostly try to guide you through what you do as you see your patients, what we do here is just as a guide. And as always, we'll always request you, in case that you have any question, forward it to us. Dr. Paul is always ready to help you answer it. If you have any patient that needs help, let us know. We'll create an account for you in our platform, and you will use it to send your cases. Thank you all.
And thank you so much.
Thank you so much. And to you all, have a good evening, and bye-bye, everyone.